My name is Carol Johnson, Vice President of Government Markets at MCG, and I'm very pleased to welcome you to our webinar today. Our presenters today are going to be first Pam Applegate, Tanel Kress, and Leanne Castro. So we'll start our presentation with Pam.
Hello, everyone. We thought we'd start today by talking about Livanta and our role as the Beneficiary and Family-Centered Care Quality Improvement Organization. We are the BFCC-QIO authorized by Medicare to review inpatient hospital services in 2 of the areas of the United States. The Area 1, which is the Northeast United States, as well as Puerto Rico and the Virgin Islands, and Area 5, comprised of the Western United States and the Pacific Territories. We review Medicare cases to determine if the services meet medically accepted standards of care, are medically necessary, and are delivered in the most appropriate setting. We also perform MSDRG validation on all cases selected for review to ensure that the diagnosis and procedure codes reported and the resulting DRG payment are supported by the documentation in the medical record. Some frequently asked questions that we get: does CMS dictate or endorse which guidelines that Livanta or KeyPro use? And no, CMS does not endorse any guidelines for the QIOs to use in their review. As a provider, can I be successful if I use a different source of guidelines? And the answer to that is absolutely, that guidelines are just that, guidelines. And while it makes it more efficient and consistent to use standard guidelines, it's not necessary to get to the same conclusion. And in all cases, remember, there's always an opportunity for discussion before any final determination is communicated on a review. The third question is, am I required to use the same clinical guidelines that my QIO uses? And absolutely, there's no requirement to use the same or, in fact, any clinical guidelines. The BFCC-QIOs are required to review hospital requests for higher weighted DRG assignments, as addressed in 42 CFR. These reviews do not apply to hospitals that are not under PPS or that are MCOs. The way we get our reviews for that is the hospital submits requests for higher weighted DRGs directly to the intermediary, to the MACs, for processing in the form of a claim adjustment. These adjustments are then paid by the MACs and subsequently selected in the following month by CMS for QIO review on a post-payment basis. Each of these hospital requested adjustments that results in a higher weighted DRG requires both a medical necessity review and a DRG validation. So 2 types of reviews are done on each of these claims. If a potential quality of care concern is suspected during the review, the claim also must undergo a quality review. DRG validation is performed by accredited and experienced hospital coders at both of the QIOs, and the following information is what is looked at. The coder determines if the diagnoses, procedures, discharge status, and present on admission status agree on the claim and the information in the medical record. We do have a physician review process. If medical judgment is needed for diagnostic or procedural information, or to determine the medical necessity of the admission, the medical record is referred for physician review. All of our physicians who do reviews are practicing physicians with current licenses in the geographic area of the provider. Cases are referred to physician reviewers within their area of specialty or subspecialty, and all admission denial determinations are made by physician reviewers. The notification process for higher weighted DRGs: if the review of the case results in an approval determination for both the medical necessity of the admission and the higher weighted DRG, no notices are sent to the hospital. This is truly a case of no news is good news. If the initial review of the case results in a question, whether it be for the appropriateness of the admission or the DRG assigned. Notification is sent to the hospital liaison and the attending physician with an opportunity for written discussion. And final determination letters are sent to the hospital liaison, the attending physician, and the MAC after the opportunity for discussion has elapsed, whether or not we've received any response from the provider. There is a re-review process. After the final determination, the hospital has an additional 60 days to request a re-review of the case by a different reviewer. The re-reviewer takes into consideration any and all information from the original review and any additional information may have been sent in by the hospital. Re-review results are again forwarded to the hospital liaison, the attending physician, and the MAC. And according as specified in 42 CFR, no additional review or appeal is available to the hospital at this point. By the QIO process is done at that point.
Hi, my name is Tennille Kress. I'm a RHIT, a senior review coding specialist with Livanta. I'm responsible for performing the higher weighted DRG selection. And the first slide that we will go over is, I'm not going to read it all. It's the BFCC-QIO Midnight Claim Review Guideline. CMS enacted the 2 midnight rule, as we're all familiar with, and then later went back and provided further instruction for the BFCC-QIOs to use the following graphic to determine if a hospital stay is payable under Part A. Just taking a brief moment to kind of look at it. There was, as I said, further education provided looking at the 2 midnights, looking for the 2 midnights or greater order. Then taking a step further, did the patient need hospital care? In these cases, some of them we are referring to physician reviewer if necessary, and that walks you through that whole process that we go through. Just looking at it, if you go down to step 6, it's looking at patient history and comorbidities, current medical needs, severity of signs and symptoms, risk of any adverse event. So again, this is CMS's direction to the BFCC-QIO in regards to how to process admission reviews and looking at the 2 midnights. In this case, what was of concern, I believe, was that some of the reviews didn't feel like the 2 midnights or longer was an appropriate observation, so those were getting sent out to physician review. But as again, CMS came back and gave us further information to review those. So this is the guideline that we are using for 2 midnight. In the case studies that we are doing, we will assume that all of this has been met. But we will also, I will walk you through some case studies on some more, maybe less common, more common difficult cases to get admission criteria through. We won't be doing any ones like CHF or like an acute myocardial infarction because those are pretty easy to go through. So the first case study I want to look at is a 67-year-old male who presented to the emergency department after falling 4 to 5 feet from a ladder. He complained of neck pain, numbness, tingling, and weakness of the right upper extremity and right lower extremity. The radiology revealed no fractures, so it was a negative workup. The emergency room record documented light bone weakness, right leg, 3 out of 5 with decreased sensation. In addition, the patient was seen by neurology and with a right lower extremity exam, showing again what the emergency room did with 3 out of 5 from motor. In this case, it was very beneficial to have the neurology see the patient. So when we go to the MCG guidelines criteria, through the quick search, I'm going to show you 2 different ways. One showing searching by the admission diagnosis or complaint, and then in another case study I'll show you how to search by ICD-10 code. So on this one we're entering weakness under quick search. The patient presented with weakness with his right upper extremity, and the documentation supports it. This is the principal reason for admission. So then after entering weakness, you click on Go. And that leads you to this extremely long list which is very beneficial to give you multiple options, different guidelines that include weakness. And so those are the guidelines that we'll display for you. The guideline that we're going to be interested in looking at is MGN, and that's a GRG. So we're going to do a neurology GRG for the weakness. After clicking on that guideline, it takes you to the clinical indications for admission to inpatient. You'll see you can expand or collapse these areas with the plus sign. And it says hospital admission is needed for appropriate care of the patient because of one or more of the following. Due to the patient of having a new onset of severe neurological symptom requiring inpatient care is the one that I selected for this case. As you remember, he fell from the ladder and was experiencing a new onset of weakness and tingling. After you go and you collapse or expand that area, you'll see the different options that are under there. Inpatient care is indicated by one or more of the following: aphasia, weakness, paralysis, spasticity, ataxia, amnesia, involuntary movements, vertigo, and other symptoms, and Guillain-Barré syndrome. In this case, looking back at the case summary, the patient had weakness of the right leg, 3 out of 5, with decreased sensation. The patient was seen by neurology, which confirmed the motor weakness. So under weakness, in the parentheses, you see that it says a grade 3 or less. By having the 3 out of 5, the patient meets inpatient criteria based on this weakness. So in a case that would look like presenting with weakness that they might not meet inpatient criteria, these guidelines are very helpful in walking you through and finding symptoms that you might not normally think would meet inpatient criteria. So again, I think in this case, having the neurology consultation to back up that further information of the motor weakness was helpful in being able to document it. So this patient did meet inpatient criteria using this criteria based on the 3 out of 5 weakness. Moving on to our second case study, we had an 88-year-old male that presented to the emergency department with altered level of consciousness at his home. The following vital signs were a pulse of 81, a BP of 135/73, a respiratory rate of 16, a temperature of 99.7, and saturations of 96 on room air, which the emergency physician determined was adequate for this patient. You can see the following lab results, so we'll not read through all those because I do have notes on the screens following. In this case, I went through and used the ICD-10 code J18.9 and then clicked Enter after that, or clicked Go. As you can tell, J18.9 is pneumonia that was documented and supported in the chest x-ray that was done in the emergency room. That leads you to MCG guideline code M282, pneumonia community acquired, which is the guideline that we're using for this case. Again, the clinical indications for admission to inpatient care. Admission is indicated for one or more of the following. In this case, I did not put the notes back on there, but the patient was not hypoxic. The physician, emergency room physician, determined his SATs were appropriate. He did not have any hemodynamic instability, and the following listed there. So I go down to the moderate risk category. You can also use the intermediate risk category. And using the PSI calculator is what I'm going to demonstrate for you now on a patient. When you click on the PSI calculator, this is the screen that will show, asking the age, gender, nursing home resident, and the following information. On the next screen, I will show you the inputted information for the patient. He was an 82-year-old male. He had renal disease and altered mental status. He did not have any of the other following information or diagnosis. After you enter that information, if you click the Calculate button, it will calculate the score for you and the class. So referring back to the initial page of the guidelines, you will see the pneumonia severity index of a class 4 or 5. So by admission indicating one or more under the moderate risk category or high risk category for a patient, the patient's class was a 4 and inpatient care was appropriate. So the admission was necessary. That is the end, and we are open for questions.
Okay, so question number 1 is, if the inpatient stay is denied, is the beneficiary notified?
Inpatient stay on a higher weighted DRG or for any inpatient stay is denied at the final decision determination, then yes, the beneficiary is notified.
Okay. Right. What if the provider only documented weakness, or what if 4 out of 5 weakness is documented?
This is Tennille. In that case, if the 4 out of 5 is documented, and if we cannot get the patient to meet inpatient criteria on Milliman, that is when it would reflect back to the 2 midnight.
Okay, thank you. And what if the patient left after 1 midnight for the previous case?
Okay, this is a good question. CMS has a lot of information on their website regarding 2 midnight stays. They have a frequently asked question page. In short, what you would be looking for is, did the patient leave against medical advice? Was the 2 midnight expected, but the patient unexpectedly improved quickly and was able to be discharged early? In that case, we're looking for documentation, as CMS says, to look for documentation of that in regards in the medical record documentation. There could be, was the patient transferred? So again, reflecting back to the 2 midnight rule, and again, CMS has excellent frequently asked questions on their website pertaining to if the patient leaves prior to that 2nd midnight.
Okay. Okay. This reflects back to question around the guidelines. So if Livanta uses MCG, what if the facility had used interqual criteria and the patient met per interqual but not MCG? Would this be something taken into consideration during the discussion period?
Absolutely. Right. There's no requirement for any specific criteria set.
Right. One question came in. Are you just doing admission review on the length of stay less than 2 midnights only?
The cases we're talking about now that some of our reviewers use MCG for are the higher weighted DRG. They're not at all the 0 and 1 day stays that are selected by the 2 midnight reviews. They're hospital requested by the hospital making an adjustment to the claim that results in a higher payment.
How does case 1 meet the 2 midnight benchmark? If deemed non-surgical, what leads to the expectation for a 2 midnight stay?
Again, that would go back to the documentation in the medical record by the attending physician of the expectation of the patient meaning 2 midnights or more. I think that's what's really important to remember. While we showed you case studies using the Milliman Care Guidelines, there is also the 2 midnight rule in effect.
Okay. So if the patient meets inpatient criteria and has less than a 2 midnight stay, will this not be denied?
Again, that's going to be based on medical record documentation. We're still directed by CMS to review for the 2 midnight. So we're still looking for documentation of a 2 midnight or more expected stay. And again, there are exceptions to that stay, and those can be found on the CMS website under the frequently asked questions. It's kind of hard not having a medical record in front of me to directly answer those.
Okay. Would you use the admission diagnosis or the principal diagnosis after testing for your MCG guideline?
While using MCG guideline, we would use the principal diagnosis or the diagnosis found after the hospital stay to have reasoned the hospitalization. Now, I know that's kind of confusing. In the weakness case, that actually was the principal diagnosis.
Okay. Next question is, how would you handle a one-day stay that was preceded by a period of observation?
Again, that's going to depend on the medical record without having it in front of me. If it's a one-day stay that was preceded by observation, that's going to depend on the time in observation. It's going to depend on the type of documentation provided by the physician. And those, again, can be found under the frequently asked questions, the timing in observation, and then the 2 midnight that is addressed in their frequently asked questions. So a lot of it is based on your medical record documentation and having excellent documentation regarding the intent. And, you know, we're not there. It's the physician that's there and, you know, basing on their medical judgment.
Okay, thank you. So when upheld appeals are forwarded to Maximus, Maximus does not seem to acknowledge the use of guidelines such as MCG in the review of these appeals. Can you comment on that?
I cannot comment on that. They are a different contractor, and I am not familiar with their exact review process. Sorry.
Okay. All right. And then question from Carmela. Can you go back to the graphic regarding the review process for the 2 midnight ruling?
Yes.
Right. It states that the 2 midnights start with a valid inpatient admission. However, CMS states that even observation time counts toward 2 midnights. Can you clarify, please?
That would be correct. Observation time for the CMS 2 midnight ruling does count towards that. This is a high-level graphic, so not everything is completely listed in it. It's a graphic for the QIOs to use, and we are aware that observation does count towards that time.
All right. What physician documentation would be required to define that a patient required inpatient status, even if the physician felt less than 2 midnights would be required?
Well, that's a good one. Again, I think you're going to have to go to the CMS frequently asked questions on that one or provide more information. I think there might be cases out there that, you know, they don't put the 2 midnight on, but I can't speak directly to those without having medical record documentation. I'm sorry.
Yeah, those are the case-by-case exceptions, which would depend on what the documentation is in the record. But if the physician admits a patient and does not expect the patient to be 2 midnights, but firmly believes that they require inpatient admission, you know, whatever the thought process is for that decision should be documented.
Okay. Next question is, are you saying that if the patient didn't meet criteria for admission, but we are expected and kept the patient 3 nights, this would be paid under inpatient? And that's assuming you have an appropriate order.
Assuming there's an appropriate order and the patient received necessary hospital services for those days, then yes.
If the facility uses a second-level physician review for medical necessity, will Livanta speak to the physician from that company?
For higher-weighted DRG, we don't do verbal discussions, but when we send the letter to the QIO liaison, the discussion letter, and the attending physician, they can, you know, incorporate that physician in their response, that physician's information in their response.
Next question. Since January 2016, a 1 midnight expectation can be inpatient on a case-by-case basis. How will you audit those cases?
I think that's what we were just talking about a minute ago, when the case-by-case basis with a physician admits a patient but does not expect a 2 midnight stay, but feels strongly that the patient needs inpatient care, it would come down to the documentation that supports his decision.
All right, next question is, what part of the ICD-10 are you using?
I guess we need further clarification on that one. We're using ICD-10-CM, that's the diagnosis codes, and ICD-10-PCS is what we use for the procedure codes.
All right, and I have questions here from Bert. And Bert, you may need to clarify here, but if the history says AMS, the PE says alert and oriented, which prevails?
I think in that case, again, it's going to go back to is there further documentation that you can clarify that in the record, looking at other parts of the medical record. I can't say which prevails. That's conflicting documentation. There might be a good opportunity for you to present coding query or clinical documentation question to the physician if it's not further clarified.
All right, I think we have time for just a few more questions. If the patient's meeting criteria for observation for 2 midnights, do they meet for inpatient? And if the patient is meeting criteria for observation for 2 midnights, do they meet for inpatient after those 2 midnights if they need to remain in the hospital?
Again, that's going to go back to the intent of the physician and having an appropriate order in the chart.
Okay. All right. Question for Deborah. Is the 2 midnight chart guideline available on the CMS website?
Yes, it is, as well as our website.
Okay. If a patient has a surgery on the CMS inpatient-only list and only stays 1 midnight, would this patient be denied for inpatient stay without a statement? The patient
No,
unexpectedly?
Absolutely not.
Okay. It's on the inpatient-only list. That's dictated by CMS, so that would be approved.
Okay. All right. That's all the questions I have this time. If there's others, we'll come back to those at the end of our presentation. So we will move to our next presenter.
Hello, everyone. Another type of review that Livanta is responsible for is called the Quality of Care Review. A Quality of Care Review initiates as a result of a complaint that the QIO received from a Medicare beneficiary or their representative, another agency, or anyone else in the community. The review focus is to answer the question on whether the clinical healthcare services provided to the Medicare beneficiary meets professionally recognized standards of care. In conducting a quality review, the QIO will gather information of the reported complaint or quality of care concern, obtain the medical records from the provider, recommend a standard of care that is relevant to the concern, and coordinate a peer-to-peer review. That is, the quality of care concern or the reported problem will be reviewed by a peer physician or other practitioner that matches as closely as possible to the licensure, specialty, and practice setting of who the complaint is against. The person, or that is the person who is responsible and gave that specific care or made the clinical decision. As the QIO considers a published resource to use, we know that the recognized standards of care must have professionally developed language that has a range of acceptable variation from a norm or criteria. As we mentioned before, while CMS does not endorse nor require the QIO to use a specific reference source, one that we may elect to use is from the MCG product line. And so, for example, of the MCG information found, the areas that we may consider would be prevention, clinical indications for inpatient care, alternatives to inpatient care, hospital care, discharge, or references. So to show you how we might use MCG for standards of care, let me give you an example of a quality of care concern that we received. So in this situation, Livanta receives a call from a family member who reports that the patient received a pressure ulcer while she was in the hospital. So what our staff would do is by, again, using the quick search function, we would type in pressure ulcers, and then based on the list that's generated, the staff member will use the guideline codes, the product type, and then the title to select the most appropriate reference. So for this situation, we're using M7045. Once you click on that link, that selected skin and wound care, common complications and conditions. So for this information, as you can see right below it, this section will entail prevention, clinical indications for inpatient care, hospital care, discharge, references, definitions, and codes. So in the first part where it's listed as prevention, many factors such as the patient's clinical presentation, continuity of care, other settings where previous care was received, such as another hospital, skilled nursing facility, or a home health, or even the fact that maybe the patient had no history. The information found in this prevention section could be recommended to the peer reviewer to be used as a standard of care reference. In the following section, clinical indications for inpatient care, this information could be used as a reference for the peer reviewer related to ongoing care when the patient is in an acute setting. Whereas in this next slide, this would be alternatives to inpatient care if it was home health or a recovery facility. The peer reviewer could use this information to determine whether the care was medically necessary or the level of care was given in the most appropriate setting based on clinical presentation and the treatment plan. The next section of this link is for the hospital care assessment and evaluation factors. Again, depending on the type of ulcer, the information can give what physical evaluation should look like, potential elements of the treatment plan. And just to note that while the review coordinator can recommend the standard of care to the peer reviewer can adopt this reference or select another standard of care. The entire determination on whether the care met standards of care, it will also be influenced by the reviewer's clinical practice knowledge, as we said before, documentation found in the medical record, and the information that was submitted by the person who filed the complaint. This last slide shows the last part of the link information, which is discharge criteria and the reference and abstract information for this pressure ulcer guidelines. Again, the quick information that I just showed you and using this example is just another way that the QIO might use the MCG product to assist us in our quality of care reviews. With that being said, that concludes our slide presentations. Are there any questions regarding quality of care and standards of care, or perhaps any other questions for the other presenters? And it kind of looks like there's a whole lot.
Thank you, Leanne. So the first question is, if the patient does not appear to meet criteria for inpatient, but the physician writes order for inpatient and documents that he or she expects a 2-midnight stay, is this considered a true inpatient?
If the patient does not meet criteria for inpatient, but the physician writes the order for inpatient, if the physician writes the order for the 2 midnight and he expects it to be a 2 midnight stay, yes, based on the 2 midnight claim, based on the 2 midnight ruling, without looking at further documentation, just basing it off this question, yes, it would meet that 2 midnight inpatient stay criteria.
Okay. Next question. When a quality of appeal is denied, is there a second level of appeal?
Just to be clear, there are two different types. There's an additional type of review that we do, which we call an appeal review, and those are for notice of Medicare discharge. The quality that I'm referring to is, yes, there is a discussion of opportunity, and so if you're referring that to as an appeal within the quality of care review, yes, there is 2 opportunities for further discussion.
Okay, thank you. All right, does a patient need to stay over a midnight for a procedure on the CMS inpatient list? I think we've had this earlier.
Yeah, a similar question earlier. If the procedure is on the CMS inpatient list only, then that is considered an inpatient.
Okay. Next question, is there only one level of review?
I'm not sure which, I'm assuming that are they speaking to the DRG process or our process? There are opportunities for multiple level of reviews. Pam, do you have an idea on what they might be referring to?
Okay,
our DRG process, we have, as we introduced, we have the opportunity for discussion. The first preliminary letter goes out to is sent to the attending physician and the QIO liaison with an opportunity for discussion. That's the first level of appeal. And second, once you get a final letter, you still have an opportunity, 60 days, to ask for a re-review from a different reviewer.
Next question. Does necessary hospital care and meeting guidelines mean the same thing?
I'll go ahead and take this one, or take a stab at it. I would say no, that it doesn't mean the same thing. Guidelines, I'm assuming we're referring to like Milliman Care Guidelines and Interqual Guidelines. Again, that goes back to looking at the Two-Midnight Review Guide. And I think if you would reference step 4, reading the box, was it reasonable for the admitting physician to expect the patient to require medically necessary hospital services? So that's something, if they're admitting the patient, it needs to be medically necessary hospital services. So I hope that answers your question. I would basically, guidelines and medical necessity, I think, could be viewed as two separate things.
Okay. All right. What about if the discharge is delayed because you could not effect a safe discharge?
CMS has given us guidance on that also. One of the acceptable reasons for keeping a patient is when they cannot be safely discharged. So even if the patient didn't stay 2 midnights, or if they did stay 2 midnights but didn't receive services, if there's documentation for the reason why they could not be safely discharged, that's acceptable.
Okay. All right, next question. What happens if an elderly patient comes in for a pubic fracture, which traditionally has not met criteria for inpatient stay, but the patient is elderly, lives alone, and gets only PO narcotics for pain control? Would it meet criteria?
Again, that is can go back to the 2 midnight. If the physician feels that the patient expects 2 midnights or longer and feels that it is medically necessary. I do know what you're referring to. If you use the guidelines, PO medicine for pain control is not typically something that requires inpatient care, but without looking at the medical record, I can't completely answer that again, so I would go back to the 2 midnight claim.
Okay. And then I have a question from Nakaba. How long has this process been in effect, and what brought this change?
Pam, I am trying to think how long it's been a couple of years.
I'm not sure there is a change. The QIOs have been looking at quality of care reviews and higher weighted DRGs for several scopes of work now. I mean, many scopes of work, higher weighted DRGs for less so, but there really hasn't been a change. Unless
the question's referring to the 2 midnight claim, that was a federal law that was passed, and you can go out to the CMS website and look at the federal regulation that was passed and the reason that it was passed.
If the patient diagnosis is not on the Medicare-only list, the physician certifies the patient will stay past 2 midnights, but the stay is less than 48 hours. Is this observation or inpatient?
Okay, I can't answer that specifically without looking at the record. Not to be boring and keep saying the same thing. Again, referring back to the CMS 2 midnight graphic, you can look under step 4, and there is a red annotated area. And it's called unforeseen circumstances, basically where it results in a shorter stay than 2 midnight. That could be a death, a transfer, AMA, clinical improvement, election of hospice. So basically it's going to go back to your physician documentation of why that stay ended up being less than the 2 midnights.
Okay. Okay. And then we have a question, the safe discharge exception, is that written in the CMS policy?
This is Pam. I'm not aware of a policy, but CMS did give us that guidance during some of the training for the 2 midnight rule.
Okay. All right. If a patient has no acute care need for hospitalization but needs placement, is not safe to discharge home, and there's no option other than custodial placement, and the patient stays more than 2 days, does this qualify for inpatient under the 2 midnight rule?
Probably not, unless the patient had already been receiving services and could not be safely discharged and they were just, waiting. But if they just came in for placement and did not receive hospital services necessarily, probably not. But again, it's hard to speak in generalities.
Okay. All right, next question. Do Medicare Advantage plans adhere to the 2 midnight ruling?
This is Tennille. I'm going to speak in a generality. I do not know firsthand. Pam, I don't know if you do. It's a CMS federal regulation, so I would assume that they do, but I do not know for certain.
Can a patient's stay be denied if the medications they're being treated with are deemed to have similar bioavailability, whether the medications are IV or oral?
Again, you're going to need to have a medical record in front of us to be able to answer that. And again, back to the 2 midnight, the 2 midnight expectation. It's not just about going through the criteria and finding criteria to get the patient admitted. It's an admission review. We're looking at multiple things, including the 2 midnight order.
Okay. And next question, is patient with MSTEMI with MD documentation to transfer to higher level of care for intervention and stays 1 midnight? Does this meet inpatient?
Again, these questions are kind of hard to answer without a medical record. If there's a 2 midnight order on there, they're expecting them to be there 2 midnights or longer. One of the unforeseen circumstances would be a transfer. I'm assuming they're a transfer to a higher level of care, meaning that they're transferring them to another facility. I'm not sure if that's what they're intending by that or not.
Okay. All right, and I think we have time for one more question. Does OBS count toward 3-night stay for SNF benefits?
That answer can be found on the CMS website, and the answer is no.
Okay. All right. So that's all the time we have left for today's presentation. So we want to thank you for all of your questions today. We've had a very informative presentation. Thank you for your attendance, for your questions. For information, again, you can reach out to your MCG account manager, sales executive, also to the Livanta website, which is on your screen now. Thank you all, and have a great day.